Thank you very much for that kind introduction, and it's my pleasure to present my perspective on perioperative health policy, our role in the post-pandemic world. Now, I am speaking today in my role as Professor of Anesthesiology and Critical Care, although, as many of you are aware, I am currently the Chief Medical Officer for the for Medicare and Medicaid Services and Director of the Center for Clinical Standard and Quality, and certainly that role informs this talk. Now, I'm really proud that I remain a clinician, that, on the right-hand side, you see me getting fit tested, that I was still the chair of the Department of Anesthesiology and Critical Care when the pandemic began back in February, March of 2020, that I remained for the first 4 months until July 6, 2020, and then came into the agency. But in fact, I still gave anesthesia about 2 to 3 times a month, and understand what the clinicians, what you're going through, and the exhaustion from the care of these high-risk patients and the continued activities we need to do to protect ourselves, our family, our loved ones, while still taking care of individuals. And that really has informed my way of thinking. Now, the premise for the direction in which the United States has been going over a number of years, for 1 to 2 decades in many ways, is really going from volume to value. And this is the Healthcare Learning Action Network, the LAN, and talking really about traditional fee-for-service, and I'll come back to that Category 1 payment mechanism with no link to quality and value, that Category 2 where there's a link to quality and value, and many of you may remember the Surgical Care Improvement Project, the SCIP measures, that Category 3, which over the last decade has been a focus of sort of bundled payments, the advanced payment models initially starting as an upside only, but now really having up and downside, and really getting to this Category 4 of population-based payment, the total cost of care. And that's really the direction that CMS has been moving, and I'll talk more about the Innovation Center's strategic plan. But really that idea that it's the providers who are going to take ownership for that total cost, and therefore having a more accountable relationship is critical. Now, these are the strategic pillars of the current administrator, Chiquita Brooks-LaSure. And as you see here, and I want to come back to some of these themes, one is advancing equity, and that's really where we begin. And what we've seen during the public health emergency is really the premise that there were groups left behind, and we need to ensure that doesn't happen again. We certainly want to expand access in building on the Affordable Care Act and its access to quality, and I'll talk more about that. There's a marked interest in engaging our partners and in our policymaking, and I'll end with that. Driving innovation, and that's some of the things that I hope we in anesthesia continue to do. Protecting our programs, and this is really about the Medicare Trust Fund and making sure that we have a sustainable future. And lastly, how we at CMS work. Now, health equity has been a major theme that you hear about constantly if you're listening to healthcare policy space and what we expect boards to be engaged in, trustees to be engaged in, providers. And it really means, and I think this is an important definition, the attainment of the highest level of health for all people. This is CMS's official definition, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language. There's a lot about cultural and language appropriate services, or other factors that affect access to care and health outcomes. And you see that CMS is working to advance health equity by designing, implementing, operationalizing policies and programs that support health for all people served by our programs, eliminating avoidable differences in health outcomes experienced by people who are disadvantaged or underserved, and providing the care and support to our enrollees need to thrive. And, I heard a phenomenal story from the secretary recently when he was talking about cultural and language appropriate services. It's not just when we give consent or when we care for individuals or regarding their pain that we're able to converse with them in their own language, but actually understand the culture under which they live in. It's more than, and he described his father who spoke Spanish only, more than what he said and the ability to talk to him, but understand how he's thinking about interfacing with the healthcare system. And I think we have a lot of opportunity in that space. That the Innovation Center, so talking about that, achieving equitable outcomes through high quality, affordable, person-centered care, is really focused on driving accountable care, so having an accountable care relationship. That means whether it's a primary caregiver, or for example, for people with heart failure, it might be their cardiologist, or with cancer, their oncologist, making sure there's someone who's really saying this is the best care. That many of our models, and you may have heard about ACO REACH, which has replaced the direct contracting model, has really ensured that we don't just take care of those with higher economic status, but ensure we really take care of the population of the area to which that entity, that ACO, accountable care organization, that hospital serves. They want to support innovation out at the field, address affordability, and really partnering to achieve system confirmation. And if you look at what happened during COVID-19, I just picked this picture of all these waves that we've had of, the original variant and what we had to deal with in hospitalizations and ICU beds. And then, of course, that really large second wave right before the vaccine occurred. And really, even after the vaccine, because of some of the issues that are occurring, and with Omicron, really seeing more waves and how it's affected hospitalizations. And what did I learn during that time? And one of the key things I learned in my role overseeing the nursing home entities, and it's all about implementation. We know a lot about implementation of handoffs, both in the OR and the ICU, implementation of emergencies, implementation of difficult airway algorithms. And what I saw in my role overseeing the nursing homes was that we would put out guidances, but that didn't help. We needed to understand how to implement them. And the lessons we have learned from COVID-19, particularly in the nursing homes for me, but in general, is that these lessons will inform future policies and initiatives to really make it that we're ready to implement these best practices when we have times of stress. And that's really something anesthesiologists have understood, is that idea of having those cards and that we practice in the simulation, in situ simulation in particular, that helps us. Now, who's disproportionately affected? And we know, as I talked about equity, that this particular virus has affected Black or African Americans much more as far as death, et cetera, American Indian or Alaska Native, the Hispanic population, that post-pandemic, we really need to look into these questions. It's not only in hospital disparities, but between hospital disparities and where these individuals go for their care. Now, I borrowed this slide from talks I've given about really what I think about quality improvement and the conditions of participation. This is what we get surveyed to by the Joint Commission, by the state survey organizations. And post-pandemic, how are we going to ensure that that is consistent throughout the country? And I'm working closely with the Joint Commission. That we have payment models to get us to that highest quality, best value care within a resilient framework. We also have quality improvement, something we in anesthesia focus a lot, and quality measures. And I'll talk about the quality measures that we're looking at. And post-pandemic, again, a slide I borrowed from my official capacity, is we need to do emergency preparedness better. We need to not have it come off a shelf, but that's what we in anesthesia do. We should be helping our hospitals understand how to prepare for weather emergencies or the next public health emergency. In the beginning of the pandemic, we were there. We were at the front line. Now, a lot of our actions have been forgotten. We need to remind the leadership of the hospitals and ASCs and the places we work about our role and how we can continue to help. I'll talk more about equity and, as I said, consistent surveying. And how do we get paid? This is a talk on health policy. We have fee for service. We have value-based care in which we're paid, or they pay a lump sum to the hospital or to the entity, and we get a share of it. And how will we think about taking up and downside risk? Or are we getting paid by widgets, by sort of the volume we do? Or are we getting paid by salary or some combination, including a link to quality? Now, one of the things to understand is under the physician fee schedule, which should be coming out soon, there is a certain number of relative value units, the amount of work physicians do. And that includes the work, the professional time intensity, the plastics expenses, and the malpractice. And what has to happen is that essentially every year for Medicare, there's only a small increase in the total amount that can be paid to physicians. This was the doc fix that needed to happen, but there's still a relative amount. So if we add in new CPT or ICD-9 codes in which people get paid, for example, for care coordination, the total RVUs in the system may increase, and therefore the conversion factor, the amount we get paid for each ASA unit, might go down, which happened recently. So that as we look to the future, we have to recognize that there's going to be limits on how much we will be paid for each unit in the traditional system. And as others do more care coordination, that conversion factor could go down. So the way we could make it up is by linking to quality programs. We've moved from traditional MIPS to MIPS value pathways. This is the way you get paid clinicians for the quality component of what you do. You know, from the AQI, the Anesthesia Quality Institute, and a lot of our measures. And what CMS saw, and to be honest, what I observed when I was still the chair at Penn, is if we were part of One Tax ID, we actually could be measured on how the primary caregiver gave the flu vaccine, which is not a measure of what we do in anesthesia. So we're going to what's called sub-TIN or sub-tax ID number, and we're looking at individual specialties and coordinating around that specialty, and that's the MIPS value pathways. The other thing, and I'll come back to MVPs, is people, I'm sure, are aware of the requirements around surprise billing, that there's been a number of changes to our original proposals out of CMS, but that the ability to balance bill is being limited, and that will affect total compensation, and therefore how, again, we get paid. because there are providers, and anesthesia is one of those. Emergency medicine is two, that people will come to the surgeon or the hospital and not realize that the physician may be out of network or may be allowed to balance bill. And this really limits the amount you're able to receive in compensation. The vision of using quality measures is really to improve the health outcomes and deliver value by empowering people to make informed choices and driving improvement, getting to that higher level that I talked about. And CMS just released their national quality strategy, really trying to embed quality across the entire care journey, from birth to death, advancing health equity, engaging around patient-centered care, really need to focus on zero preventable harm. And this gets back to the Institute of Medicine to Err as Human, that we were at the center and at the beginning of the safety movement, strengthen our resiliency, trying to get to more digital measures, and most of us have electronic medical records now, incentivizing technology, and aligning across all our programs. And what was observed during the public health emergency, during the pandemic, is all the positives that we saw for the 5 years before in health-associated infections, in falls, in nursing homes and hospitals, got wiped out in that first 6 to 9 months, that we regress back to sort of the baseline from 5 years earlier. And we don't know whether this was related to COVID patients or just the stressors, as we all remember what the stress of taking care of individuals in our complete PPE. But we did write an editorial, myself with my colleagues at CDC, that we want to renew our focus on patient safety. And we, as anesthesiologists, really should lead it, that we knew how to do it, and we're seeking better, more deeply embedded solutions. It's not just about the checklist, but the checklist in a system of safety. And remember, there's no true healthcare quality and safety without equity, and embedding that into it too. So let's go back to the MIPS value pathways. And our goal at CMS is to go by 2028. CMS's goal is to really get to everything going from traditional MIPS to MIPS value pathways. And the premise is, instead of saying any measures of quality, any measures of cost, any measures of improvement activities, aligning them around measure sets. Having fewer of them, could be only 3 quality measures from 6. Having fewer improvement activities, maybe just 2. Having a aligned cost measure and interoperability underneath. And I'm really proud that anesthesia was one of the first. And in fact, not only can they do it in anesthesia, but lower extremity joint repair, if that's what you do a lot of, you can be part of their MVP. And these are some of the things that have been proposed. You can see anesthesia-related quality measures, anesthesia-related improvement activities, including the PSH care coordination, the really important issues, and the cost measure that we do for most of our measures. And you can see some population-based health, and these are all around things that we can be engaged in, we can lead, and we can help other specialties as being among the first of where we should be. Now, there's a couple other major themes I think I wanted to highlight that we in anesthesia can be involved in. The Secretary has made behavioral health a priority, that it's clear, as he says, the COVID-19 pandemic, the need to invest resources in our nation's mental health and address the inequities that still exist around behavioral health care. and really talking about not only mental health, but substance use services, which we know we can make a difference by engaging with our surgical colleagues, making sure they don't overprescribe opiates at the end of the case, making sure our pain physicians really are engaged in this, and making sure we have good pain relief, but keep people off the opiates quickly. In fact, we know that one of the lessons is that the opiate epidemic, this is one of the worst years, and you could see this from 2021. But that first year of the pandemic, deaths due to overdoses markedly higher. In fact, there is a suicide prevention work group within all of government to try to think about how do we get people to get care faster and get them off of their opiates. Really quite important. The other issue is maternal mortality and morbidity. And this is one that we really need to engage in. That what we've seen over the last decade and two is marked increases in severe maternal morbidity, blood transfusions, and importantly, it varies by race and ethnicity. That African American, that the Black population has 2.3 times higher rates of severe maternal morbidity than the white population. And importantly, it's not just disparities in care, because if you take someone with the same sociodemographic status and you compare women or people who are delivering at the same status, there's still differences. So there's structural racism that's clear here. And we need to get to the root of that. And the best way to do that is use our data to look and see if we have a difference. To make sure, and in fact, in graduation, the year after I stepped down as chair, that following year, I said to my residents, I never looked at the data. I never asked you to look at the data, but it's clear from this vantage point, we need to. And we're going to use these quality measures, and CMS has announced that they're going to provide confidential feedback reports based upon dual eligibility status to the individual hospitals and looking at the outcomes. And we in anesthesia should be engaged and say, can we see these report cards around the surgical outcomes? Can we see where we can make a difference? Because we need to make ourselves even more valuable or clearly valuable to the leadership of the hospitals and health systems. The other area that's of increasing importance is climate change and how that affects health equity. We know that socioeconomically disadvantaged individuals have worse health outcomes and are affected more by climate change. And there is now OCHE, the Office of Climate Change and Health Equity. We have to have acronyms. There are interagency work group. And how can we work with our hospital? Hospitals produce a large amount of greenhouse gases. Could we make a difference? And in fact, these greenhouse gases, and you can see here some pictures from Brian Cheeseborough, and working with Jody Sherman at Yale, who has been very engaged, and Jeff Feldman at Children's Hospital of Philadelphia, that all green gases are not the same. Desflurane is actually one of the worst, and you see here nitrous oxide. So you don't have to go to Altiva. You can do low fresh gas flows. You can actually eliminate, and we have very few desflurane vaporizers at Penn nowadays, that there are things that we can change that will make a difference on our health and the health of our children and the health of our patients. Really quite important. So before I end, I just really want to talk about how you can be engaged. And I think the way that you can be engaged, and we wrote this up, is that Medicare writes regs, but they do what's called notice for proposed rulemaking. They write a proposed rule and then ask for comment. Either comment on the proposal of what we do for the physician fee schedule, or comment on how we increase equity, answering a number of questions. And what surprised me in my current role is how important those answers are. And in fact, so I would urge you to be aware that when ASA says there's a new rule, to be engaged. There's something in that we have to have logical outgrowth to change a rule. So people had to comment and tell us ideas to get logical outgrowth to get the final rule. And I would urge you to be engaged. I want to end just by really thanking everyone for what they have done during the public health emergency, during the pandemic. Anesthesiologists have worked so hard. They've been under such stress. And we continue, and I hear about it every time I go to work, continue to be worried about our workforce. And I had an interesting conversation with Angela Duckworth, who wrote the book Grit. And we are the grittiest people, but we're losing some of that grit, and it's totally understandable. And what I would urge people to think about is she defines grit as practice. Well, we do that all the time, and we do simulation. We think about that at all times. Interest. Well, we have an interest in care. Purpose. There's no higher calling. But the fourth thing about grit is hope. So I think as we watch people continue to get sick, and as we continue to work, and as the attempt to really push us back to do more and more cases, that some of that hope is lost. So I just hope, my hope is that we regain some of that, so that that the system sees ways to make our jobs easier, because I really do appreciate everything everyone has done over the last 2 years. Thank you very much.